Hello, everybody. Welcome to this webinar. My name is Michael Brainin. On behalf of the World Stroke Organization, we welcome you to this wake-up call for global stroke prevention. And we have an amazing faculty assembled for you today. I myself am in Austria, Europe. But our speakers are from all over the world, from Brazil, from New Zealand, from India, and we really have a global representation here. So the background is that the World Stroke Organization developed a broader policy of prevention in the last couple of years. And we've been working together with alliances such as the Non-Communicable Disease Alliance and the World Heart Federation and so on. And following a wake-up call we published a few days ago in the Lancet, we decided it would be a good thing to have this webinar to give you more background information on what we are actually directing at. So if I may start with my presentation, first I would like to remind you that if you have any questions, please type them into the Q&A box and we will look at them as good, we'll deal and read them as good as we can and as time permits. So the overview comments I am allowed to present to you are firstly the basic facts. By 2050, we must expect 200 million stroke survivors and 106 million people with dementia. Every year thereafter, over 30 million new strokes, 12 million deaths from stroke, and almost 5 million deaths from dementia. Now, looking at stroke, why are these numbers so high and increasing at such a steep rate? If we look at the Global Burden of Disease study, we can see the contributions to this stroke epidemiology on the rise. We can see that the metabolic risks are accountable for 72% of stroke burden. And the behavioral factors, 66%. And there are some other exposure factors, I think Professor Valery Feigin will talk about, like air pollution, lead pollution, which we must consider as new risk factors. The largest risk factor of all is, of course, arterial hypertension, which accounts for 57% of all strokes. So altogether, all risk factors combined account for almost 90%. Now that's a big number. And I would like to mention that when I started out in stroke medicine, this number was somewhere around between 30 or 40%. And the research here has really been contributing very strongly, which means that we can actually predict around 80–90% of strokes happening in the world. So this is what we used to look at, you know, from the left. ApoE and genes, we start out in adult life, and there already risk factors are accumulating. And there are, of course, protective factors, and the balance between these two result perhaps in late life stroke or dementia. That's what we know about. We know about the interdependence of these risk factors. So treating one is obviously not enough, we have to treat all. But the idea of the primary prevention is to start even earlier. We're not singling out one risk factor or the other risk factor or a bundle of risk factors. We're trying to set things in motion that prevent these risk factors from spreading and gaining such importance. So what we concluded in our statement together with the World Heart Federation is that there is an urgent need to improve primary prevention of stroke and cardiovascular disease, with priority given to population-wide primary prevention strategies that would also strengthen global health systems and aid economic recovery in the wake of pandemics such as COVID-19, which means that with COVID-19 lingering upon us and haunting us, we must even be more clever than before if we want to have resources allocated to prevention that is significant and effective. In our statement on behalf of the board of the World Stroke Organization, we have recently come out with the emphasis on population-wide strategies, that the reduction of exposure to risk factors among the whole population and motivational population-wide prevention strategy with the control of risk factors in all people with increased stroke risk, regardless of level of risk. Now, what does this mean? This means that we would like to abandon the categorization of people low, moderate, and high risk categories, but we would like to advocate a continuum, a holistic prevention approach, because the low risk people actually think they have no risk, where actually they have a low risk. So that's how it goes, and how this is done, other speakers will tell you more, but of course we have to combine the community interventions with pharmacological interventions and non-pharmacological interventions to get where we want to go. And one of these concepts that, that has come out about this was the HEARTS program. And you see the district hospital, the primary healthcare, and especially the community health worker together can be effective in getting this done. So this also shows the polypill meta-analysis, which shows you the effect on systolic blood pressure reduction and total cholesterol and LDL cholesterol reduction. We'll hear more about that. So in sum, we estimate that the recommended multi-sectorial, including government, non-government organizations, healthcare policymakers, and healthcare providers, population approach would reduce stroke incidence by 50% and dementia incidence by at least 30%, while also decreasing incidence from other non-communicable diseases that share common risk factors with stroke, so we can save millions of lives worldwide. This approach would save hundreds of billions of dollars annually that should be reinvested to improve health services, preventative program, and health-related research. So this wake-up call goes to governments, to health politicians, to healthcare providers, but also to doctors, to patients, to spouses. This is a very broad call we want to start here, and you're at the beginning of this call, and I hope you will help us spread it. Thank you so much. So having said this, I think we should move on because we want to look at some data and look at the concepts in more detail. Don't see any major comments here. So it's my pleasure to introduce to you Professor Valery Feigin from New Zealand. He's Professor of Neurology and Epidemiology and Director and Professor of the National Institute for Stroke and Applied Neurosciences at the University of Auckland. He's well known for his very authoritative publications on epidemiology, prevention and management of stroke, but also dementia and traumatic brain injury. Up to now, he has delivered an incredible number of 700 research articles and a lot of other publications, including handbooks and so on. So I think nobody here at present is better equipped than Professor Feigin to go into detail about the issues of stroke prevention that need an overhaul. Valery, please.
Thank you, Michael.
Hello, I'm Valery Feigin, Professor of Neurology and Epidemiology at Auckland University of Technology, New Zealand. I'm going to talk about why current approaches to stroke prevention need an overhaul and why primary stroke prevention needs to focus on population-wide strategies. Here is my disclosure. The first question that you may ask is why we would need to worry about stroke prevention if stroke incidence and mortality rates are steadily declining since 1990, as shown on this slide. The answer is obvious. While the rates are declining, the absolute number of people who develop new stroke, die from, and survive from stroke are increasing almost exponentially. Moreover, there is evidence that even incidence rates in young people is increasing fast, and there is a growing epidemic of overweight and diabetes, especially in children, which in a few decades will result in a new increase in new stroke burden. Also, there is evidence that the lifetime risk of stroke has increased by 50% from 1995 to 2016, and now 1 in 4 of us will have a stroke in our lifetime. Most recently, there were also worrisome reports from the United States, UK, and the Netherlands about the increased mortality rates in middle-aged people. So the trend in reducing stroke incidence and mortality rates I showed you in the previous slide may soon stop and actually start to increase. So what are the issues with and some solutions for primary stroke prevention? Why does primary stroke prevention need overhaul? As you know, there are 2 main strategies for primary stroke and cardiovascular disease prevention: high absolute risk prevention strategy and population-wide strategy. The population-wide strategy is clearly the most effective strategy, as it covers all people regardless of the level of risk and allows prevention of not only cardiovascular disease, but also all other major non-communicable diseases that share common risk factors with cardiovascular disease, such as dementia, diabetes mellitus, and even subtypes of cancer. This strategy is supported by all organizations, including the World Health Organization. And a good example of just one element of this strategy is a smoking cessation campaign. And there is evidence that primary prevention is very effective with benefit-cost ratio of about 10, meaning that for every $1 spent on prevention, society gets back about $10. However, although population-wide prevention strategy was suggested by Sir Geoffrey Rose almost 40 years ago, there is still no country in the world where these strategies have been implemented in full on a national level. Smoking is just one element of this strategy. Other elements include measures to reduce salt, sugar, and alcohol intake on the population level, availability and affordability of healthy food outlets, physical activity centers, reduced air pollution, etc. The main barriers for a national implementation of these strategies are large opposition from the industry, and they often require legislative changes. Just to start smoking cessation campaign, it took us almost 50 years from the first robust evidence of the hazard of smoking to actual campaigns to reduce smoking. And even this campaign is far from over for the majority of countries. High absolute cardiovascular disease risk prevention strategy is good in applying an integrative, holistic approach to primary prevention. When the primary prevention interventions are initiated on the basis of the combined effect of various risk factors rather than just risk factors separately. It's also good for monitoring success or failure in primary cardiovascular disease prevention because it quantifies the overall cardiovascular disease risk in percentages, which are easier to compare than changes in individual risk factors. A typical example of this is heat maps of absolute cardiovascular disease risk of the World Health Organization. However, by definition, this strategy targets high-risk individuals, but it is well known that the majority of strokes and heart attacks are happening in people with low to moderate risk, and these people are effectively not covered by this strategy. Moreover, categorizing people into low and moderate risk gives them a false reassurance of protection from the risk of cardiovascular disease. For example, a 30 years old generally healthy man who smokes has systolic blood pressure of 130 and is physically ineffective has only 0.7% 5-year risk of stroke, which is very low. Would this person be motivated to reduce his blood pressure, stop smoking, be more physically active? Apparently not. But he has stage 1 hypertension, smokes, physically inactive, 3 very important risk factors for stroke. Secondly, this strategy is primarily for medical professionals, as it usually requires a blood lipid test, and the cost associated with it is prohibitive for socially disadvantaged people and the majority of people in low, middle-income countries. Thirdly, there is evidence that screening of the population for high cardiovascular disease risk might actually exacerbate socioeconomic inequalities. Fourthly, many important risk factors for stroke are actually missed from these screenings. And last but not least, there is an overwhelming evidence from randomized controlled trials totaling over 240,000 randomized patients followed up to 10 years that screening for high cardiovascular disease risk, even with some counseling, is not working. As you can see here, there is no difference between intervention, screening, and control groups in terms of stroke and ischemic heart disease incidence and mortality rates. All the evidence I just presented to you has led to a recent joint position statement of the World Stroke Organization and the World Heart Federation calling upon all governments to stop focusing on high cardiovascular disease prevention strategies and instead start focusing on population-wide cardiovascular disease primary prevention strategies. The totality of evidence, earlier this year, the World Stroke Organization accepted a declaration on the recommended strategies to be used globally to reduce the incidence of stroke by 50% and incidence of dementia by 30%. These strategies include population-wide strategies to reduce exposure to stroke risk factors and environmental risk factors across the entire lifespan. For example, smoking cessation campaigns, reducing salt and sugar in processed food, and restricted alcohol consumption, motivational mass individual prevention strategies using mobile technologies to identify individual risk and promote behavioral changes among adults, such as the World Stroke Organization endorsed AUT University free stroke riskometer app, access to low-dose blood pressure and lipid-lowering medication in one polypill for middle-aged and older adults, and investment, training, and deployment of community health workers to implement public health individual prevention strategies mentioned above. I hope these strategies will be implemented globally and that in few years we can see the reduction in stroke, dementia, and other non-communicable diseases burden. Thank you for your attention.
Thank you, Valery, for this excellent presentation. I think the point is very clear. And I'd like to ask the audience if there is currently any question to Professor Feigin, and we will also take questions at the end of the webinar. I don't...
We have a question in the chat from Rita Melifonwu saying, with the COVID-19 pandemic, what strategies for population-wide approach would you advocate, particularly in low-resource countries such as Nigeria, where Rita is based?
Yeah, I can answer right now if you like.
Well, it's not a question, it's a thank you, but you can still answer.
I think in the low middle income countries, it is particularly important to implement strategies which will not only reduce the burden of stroke, but also increase revenue from such strategies for the government to be invested back in health. Such strategies as taxation on tobacco smoking products, taxation on salt or sugary drinks, alcohol. These strategies are very important, can be implemented on the population level, and they can bring millions and millions of dollars of revenue for the government to invest back into health. Not to mention, of course, blood pressure control measurements in such countries, which is a single most important risk factor for stroke, as mentioned by Michael.
Yeah, thank you. I'm sorry, it was a question. I apologize. Yeah, okay. Any other question for the moment?
I have another one here that's from Suresh Kumar. What if the health systems as such need strengthening? What would be the best option to look at prevention strategies in these contexts?
I think I partly addressed that question in my answers to the first question. I think in the light of the COVID epidemic or pandemic, what we can see that the complications from COVID could be significantly reduced, and actually the incidence of COVID cases could be reduced if people reduce the exposure to risk factors and will have less chronic conditions like heart conditions, stroke, cerebrovascular disorders, cognitive impairment. This all will help to overcome and strengthen the health system.
Right, maybe we take a very last question and then we move on. It says here, for tobacco control, we have to fight against the tobacco industry. But for stroke, we have to deal with many industries. How should we go about this?
First of all, there should be a goodwill from the decision makers. I think stroke as a disease is a perfect instance to see impact of these strategies like tobacco cessation, tobacco companies very quickly. In a matter of a couple years, you will see the results. And convincing decision makers, finding the people who could lead these strategies, implementation of these strategies, I think that's the key to success.
Yeah, let me add, it sounds like a long road, which is probably true, but it's one epidemiological fact that if you reverse a trend like smoking in a population, the effects become visibly rather quickly. So you don't have to wait for half a generation. It's within very few years, you can see the beneficial effects. So that's an epidemiological dictum in prevention. So the answers are coming pretty straightforward pretty soon. So again, thank you, Professor Feigin, for this excellent talk and for your wonderful leadership in this whole campaign. So thank you. So we move on to another continent. We move from New Zealand to India. And it's my pleasure to welcome the Vice President of the World Stroke Organization, Professor Jairaj Pandyan, who is Principal Dean and Professor of Neurology at the Christian Medical College in Ludhiana in Punjab in India. He is also President-elect of the Indian Stroke Association. So he has been very active in prevention and setting up stroke care in rural communities, but also in large centers. He has a very effective and very big research network ongoing in India. So it's a pleasure to hear Jairaj. Please, what you have to tell us.
Thank you, Michael. Good afternoon, good morning, and good evening. So I'm going to talk about the current status of stroke prevention in low and middle income countries. I will discuss about the various evidence-based prevention strategies that are available in these countries. So this slide shows the overall burden of stroke as listed as incidence and prevalence. This is the WSO fact sheet. Globally, about 13.7 million new stroke cases occur every year, and 1 in 4 over the age of 25 will have a stroke in their lifetime. And 60% of the strokes occurred below 70 years of age, and 8% below 44 years of age, what we call the stroke in the young. And in the prevalence, there are 80 million people with stroke, and 60% below 70 years, and 10% below 44 years, and half of them are men. And so if you look at the risk factors, Professor Michael Brainin had mentioned about the risk factors for stroke. And this is a case control study from the Interstroke Research Group. This is a global study, and there are 10 risk factors for stroke. And number 1 is hypertension and regular physical activity. If you're not involved in a regular physical activity, a diet low in vegetables and fruits, smoking, alcohol, diabetes. 90% of these risk factors are modifiable, and you can prevent, if you can screen and identify these risk factors, and you can prevent strokes. So how will you classify stroke prevention? One is a primordial, that is the activities that prevent the emergence of risk factors by various methods, which I'll be discussing in the next slide. And primary is reducing the incidence of stroke, that is stroke occurrence for the first time, and secondary prevention is preventing the recurrence of stroke. So this slide summarizes the various evidence-based strategies that are available globally and also in low and middle income countries which can be implemented. For example, tobacco control, it can be applied as part of a primordial prevention and also in primary prevention. And tobacco cessation and for secondary as well as primary prevention. Healthy cities, it's primarily in the primordial prevention, and regulation of food prices, products, salt reduction, and if you do that early in the early years, then you can prevent the occurrence of risk factors. And in the primary and secondary prevention, polypills, mobile health, task shifting, sharing, WHO PEN approach, salt reduction, and healthy diet. So these are the interventions, the evidence-based interventions that can be used at a population level for global prevention of stroke. And if you look at tobacco alone, the WHO Framework Convention on Tobacco Control and the Empowered Policy Package, which focus on the reducing the demand and reducing the supply by using various methods that are listed here, and the Empower Policy Package, which is monitoring tobacco use, protecting people from tobacco, offering help to quit. So about 172 countries have adopted this policy, and 88 countries have implemented at least one policy, and one policy in at least 69% of the LMICs. And what was seen, a reduction in 53 million smokers and 22 million deaths. Just by, in what is the best effective measure for tobacco control in LMICs is raising the cost of tobacco, and for high-income countries is smoke-free legislation and mass media campaign. So these are some of the strategies which under the tobacco control which are effective in a population, in a given population. If you look at the nutrition, sugar-sweetened beverages, this study done in Mexico, when they increase the price of this sugar-sweetened beverages by 10%, the usage came down by 6%. Based on that simulation model, 10% reduction will lead to 20,000 fewer strokes. That is a huge benefit just by increasing the cost. And the polypill, this is a forest plot of all the studies, the trials that have been done, looking at the adherence of medications and also the control of blood pressure. So moving on to task shifting and mobile health. So first is a study, the trial conducted in Iran in villages. It is a polypill, the intervention is a polypill and against the minimal care, that is lifestyle changes like salt reduction, healthy diet, exercise, etc. And the villages were randomized. More than 6,800 patients were randomized to a polypill group as this intervention group, and they had a 5 years follow-up. So during follow-up, about 8.8% in the minimal group had major cardiovascular events as compared to 5.9% in the polypill group. So there is a tremendous reduction in the cardiovascular events, and the patient population was both people with and without risk factors and with and without cardiovascular disease. So it is a trial for both primary prevention and secondary prevention. But all the cardiovascular events have been clubbed together, merged together, so you won't know, how much this polypill strategy has effect on stroke incidents. And they use auxiliary healthcare professional. So the village healthcare workers were used to screen these individuals. And what they also found was that benefit in patients with high adherence, and the NNT was 34.5 to reduce one cardiovascular event. So it's a very good trial done in Iran. And a trial called Hope 4, which was done in Colombia and Malaysia. But as Professor Feigin mentioned, they looked at the high-risk category, people with poorly controlled hypertension from 30 communities, and they trained non-physician health workers to screen these patients, and they were given a tablet which is with a computer-based management algorithms, and free antihypertensive medication, statin, were provided. The primary outcome was to find out the change in the Framingham risk score at 12 months. So they were able to show a significant reduction in the risk score from in the intervention group. In the control group was 6.4, and the reduction in the intervention group was 11.1, and a difference of about 4.78. And in addition, they also found there was a reduction in blood pressure, reduction in LDL cholesterol. So this is another trial where they used community health workers and identify high-risk patients, basically high-risk patients, people with uncontrolled hypertension, and use the community health workers using the mobile technology. In Ghana, there is a small trial published. It is a pilot RCT, about 60 stroke survivors. They used a Bluetooth device attached to a smartphone where automatically the BP was uploaded into the server, into the central site coordinators, and even the medication adherence. So they were able to see in the intervention group of about 66.7% reduction in the blood pressure, and also the medication adherence, which was greater in patients who were randomized into the intervention group. So in our rural population-based stroke registry, after the incident study, we did a cluster RCT to look for the feasibility of ASHAs, that is called accredited social health activists. They are health workers in the villages, whether they will be able to monitor the blood pressure, monitor the blood sugar, and see whether there is a reduction in blood pressure. So the first 6 months was the training phase, and we were able to see the retention of the knowledge, the pre as well as post test in terms of risk factors and techniques of BP, the measurement, glucose measurement, etc. And the villages were randomized with a cluster size of 7,900, and blinded assessor measured the BP and sugar at the baseline at 6 months. The primary outcome was BP reduction. And what we saw in the rural population-based stroke registry was uncontrolled hypertension. That was the #1 risk factor. So, and many other things we added: regular advice for regular physical activity, a good diet, and cessation of smoking, alcohol consumption, etc. And these were the 2 sites. And this is one CHC where the training was implemented, and is another CHC with the ASHAs. And they were given a kit, it's called Stroke Rope Kit, where there was a manual about stroke. And there's an ASHA worker in one of the patient's houses. And they had a smartphone, the video calling facility, charging port, and a blood sugar testing, and then a BP measurement device. And they went to the villages where we already had the index stroke patients. And they used to use video calling and consult my colleague, Dr. Mahesh Kate, for advice regarding BP control, etc. So this is the baseline data. It's almost similar, except higher BP values in the intervention group. And the primary outcome, it's BP reduction. From baseline, we were able to reduce the blood pressure to about 28 millimeters reduction in systolic blood pressure, and diastolic about 13 millimeters, and a blood sugar difference about 10 milligrams. So this trial in the population-based level was able to prove that we can use the ASHAs, and we'll be able to control the risk factors, and thereby which can have effect on the stroke prevention. There is a trial which is done, which is completed in central part of India, a rural area, again using the community health workers screening for diabetes, hypertension, and stroke. And these patients were referred to the mobile clinics, monthly visits by community health workers, 3.5 years follow. Primary outcome was reduction in stroke mortality. Most probably the results will be presented in the joint ESOC and WSO Congress. This is another trial between China and India done in and published in 2015. 47 villages. They looked at high cardiovascular risk individuals more than 40 years of age, and it was a cluster RCT where mobile phone with the Android app was given with an algorithm, and community health workers were trained, and 1 year follow-up. Their intervention was BP medication, aspirin, smoking cessation, and salt reduction. Primary outcome was seen in, there was the increased use of antihypertensive drugs in the intervention group, again using the community health workers. And this trial, a smart health trial, was done in another state in India. It's a remote, it's a very interior villages with very few healthcare facilities. And again, they use community health workers, but the design was a step-wedge design where the group one, they had 3 clusters. Group one, in the first 6 months, all the 3 clusters were in the control group, the routine care, whatever was the prevalent care. And then the next 6 months, the one group of villages were randomized to intervention arm, and subsequently the group 2 was in the intervention arm, and at 19 to 24 months, all the villages were in the intervention arm. And because of this complex design, even though the primary outcome was the proportion of people below systolic blood pressure of 140, they were unable to achieve because of the complex design, and also there were few regional cultural differences, and also climate change related issues which would affect the result. But this is again empowering the community health workers. They were able to show in a high concordant group, there was a greater use of BP lowering medications. So from our group, through the Indian Stroke Clinical Trial Network, we are doing a large-scale RCT called Sprint India trial for secondary prevention of stroke, looking at the reduction of vascular events as a primary outcome. This trial is ongoing. Most probably, we should be able to complete by 2022, middle of 2022, where in the intervention arm, the patients receive text messages, video messages, and they have a workbook, and throughout the year, they have some activity to do, and outcome is assessed at 6 months and at 1 year. And the primary outcome is the vascular composite endpoint of vascular events. There are many other secondary outcomes also we have looked into it. So in conclusion, prevention of stroke is possible in LMICs. Probably a multi-pronged approach is needed, and you need to adapt to the local cultural situation. The evidence-based strategies are polypill, mobile health, task shifting using community health workers, and mobile technology is the way to move forward. So I thank my team, who particularly who worked in the rural areas, and also my team at the hospital. Thank you.
Thank you, Professor Pandian. Thank you very much for this, taking us through all these interesting studies. And I've seen a lot of questions coming in, but I would say that we should take Sheila first because of the interrelatedness of the topics, if you don't mind.
Yes,
and we take you both at the very end. So thanks again, Professor Pandian. It's my pleasure now to introduce Professor Sheila Martins. She's professor of neurology in Porto Alegre in Brazil, and works also as a founder and president of the Brazilian Stroke Network, which is a very active group in going into all direction, prevention, acute therapy, and so on. And she is, of course, also a member of the executive board, currently vice president. So, Sheila, please tell us what you have.
Thank you, Michael. It's a pleasure to be here to talk about this important topic that is the implementation of Cut Stroke in Half program in Brazil, and a little bit about the World Stroke Campaign 2020. So in Brazil, we have 200 million inhabitants, 85% in urban area. Public medical assistance is paid by federal government to all Brazilian population, is a universal, free public system of health we have only 20% additional private healthcare insurance to the population, and 80% of stroke patients are assisted in public hospitals. We have 400,000 strokes per year, more than 100,000 deaths per year. We implement a national stroke policy for acute care in 2012 with stroke units at TPA to the public health systems. We have national guidelines. We create a free online teaching course to the whole network. We have a strong public awareness campaign in the whole country in October together with World Stroke Day and World Stroke Campaign with great media coverage. And what about the priorities in prevention in Brazil? The Ministry of Health has several priorities to treat hypertension, diabetes, tobacco with a strong campaign to decrease tobacco consume, and they got it. Obesity, and to stimulate physical activity with public academies in the streets, but without a structured plan for implementation of these strategies. In 2019, we include in the line of care in Brazil the primary attention approach, and it's a very important step for us. But still we have a long lines waiting for a doctor in primary attention, you can see here. And who is our stroke patient? How does he or she lives? You can see here an example. You can see here. Here's Marina is a stroke patient. You can see her home with the she cannot walk, she cannot go out of the home because it's very difficult access.
A minha vida mudou muito mesmo.
And his son
eu trabalhei desde os 15 anos, eu não pude daí dar andamento na área
cannot work more because
problema, né?
Of his her problem.
Não consigo deixar ela sozinha, né?
She cannot stay alone, so he cannot work. He's very well informed about stroke because of the internet.
As informações, né,
you can see the conditions of home. He searched about stroke in the internet and discovered that stroke is the first or second cause of death and disability.
Vê que o problema é grave e é muito mais frequente do que a gente pensa, né? Com essas informações eu fiquei sabendo que no Brasil
So he got a lot of information about stroke in internet, but now he cannot work and he cannot access more internet for his research. So it's a very difficult situation. You can see how to get the home, and she cannot go to rehabilitation because nobody can take her to the rehabilitation. So this is the condition of our patients. And how you can change this? We have a program since 1994, a family health program in primary care, when family and community approach with a multi-professional team, a doctor, a nurse, and an auxiliary nurse, and 4 to 6 community health workers responsible for permanent and systematic follow-up of a given number of families living in a circumscribed area. And today the program covers 60 to 70% of population. So the health community workers can arrive at people's homes, giving advice, reviewing medication and risk factors, and they are working now during the pandemic. We proposed to the Ministry of Health in 2009 the Cut Stroke Health program with a clinical trial to prove the concept, to treat patients in middle risk, and to implement HEARTS program, World Health Organization, as Michael told you, in the patients with high risk. It's a partnership in public-private in Brazil, Hospital Moinhos de Vento and Ministry of Health. During the Global Stroke Alliance in March, the meeting to stimulate a global alliance to discuss the best strategies to implement evidence-based interventions in all levels of continuum care, the Cut Stroke in Half was presented by Michael here in the ministerial meeting to reach all Latin America. Here's the working group, Valery, Feigin, and me discussing with the Ministry of Health and Pan American Health Organization that is involved in implementation in Brazil. And here the official launch the program in Brazil. So despite the pandemic, we were allowed to start cutting health program in Brazil. We are 2 weeks ago, and we will start here in Porto Alegre. Here is the meeting with Health Secretary of Porto Alegre 1 week ago, discussing the details. In 8 family health program units with 1 nurse in each unit, 3 to 4 health community workers and medical students, helping in the selection of population to include in the study. You can see here the distribution in different parts of the city. For middle risk population, we will include in clinical trial in 4 arms, the stroke riskometer plus polypill alone or usual care. In high risk population, we will treat them in HEARTS program. In 9 months, we hope we have some results, reduce the levels of individual risk behaviors, cigarettes per day, increasing minutes of physical activity, more health food and reduce weight and reduce blood pressure, and raise awareness about risk factors and stroke signs. And in 3 years, we hope you can decrease stroke and cognitive decline and also myocardial infarction and cardiovascular mortality. And we are launching this in World Stroke Campaign, Don't Be the One again, because 9% of strokes can be prevented. And how to implement a virtual global campaign in World Stroke Campaign. So we will launch the biggest world's dance chain, because 1 in 4 adults will suffer a stroke, but staying active can help decrease your risk. That is why we encourage people to join the movement, and this can call for attention to find individual risk and learn more about World Stroke Campaign. So the worldwide dance chain 1 in 4 challenge, creating a global dance chain to activate WSO affiliated around the globe while spreading our stroke prevention message in a new way. The only rule is to start your dance with the last move of the previous person dance and tag some friends, and each participant will choose 4 moves. Then the next person in the chain will start their 4 moves with the previous person's last move. The idea is to put in the social media with a challenge to include children, include young people, include patients also. We will have an implementation webinar next week. And to see how you do in Brazil, and you can do the same in a virtual strategy to implement Don't Be the One campaign virtual. One campaign the whole country. With lectures to the population, test heroes in schools, origami to teach patients and children, dance class, gym class, lectures about exercise and food, and the World Stroke Day, a full presentation of stroke support organizations, musical presentations, always stimulating the campaign here. All countries, Ibero-American countries will participate too. Dancing against stroke, with dance schools participating, cut the stroke in half, and much more. This is an example what you can do virtually, connecting everybody to participate in the campaign. And We hope you can join with us in the World Stroke Campaign 2020. We'll talk a little bit more in September 22. Thank you.
Yeah, thank you, Sheila. It's a pity you can't hear the applause from everyone. So that was a wonderful presentation. And everybody's already thinking about, so thank you, thanks a lot. Now we do have a number of important questions. And I think I would like to make a comment before I pass on to Valery, who will talk about proof of efficacy of primary prevention measures. I would like to say that a lot of numbers we've seen and several studies we've seen, I think make quite clear that indicators of stroke, like hypertension and obesity and so on, can be reliably reduced by health prevention measures, polypill, whatever. So what we are looking at now is not the way to influence risk factors, but we're looking at the way to reduce the events. So we really badly need studies that show that the outcomes are reduced and the outcomes are strokes. And I'm very happy that Sheila has also included cognition as one of the outcomes in her study. So the reduction of cognitive deterioration is an outcome. So that's what we have to prove, and that's where we are at the moment. So having said this, I would like to ask Valery to comment on the question, I hope I got it right, what measures are effective in, proven effective in primary prevention?
Technology related, yes, suggestions. I think one of the technology related tools is the free stroke riskometer app recommended by the World Stroke Organization. It is based on the algorithm fully validated against Framingham stroke prediction algorithm and other commonly used algorithms, and it includes international guidelines. So in a sense, it is evidence-based app, and I would suggest it to use in combination with health workers who could reinforce the recommendations from the app and to provide tailored recommendations for the individuals, and also monitor the effect of the intervention for the individuals. Like Professor Pandian showed, that health workers and mHealth technologies working together are proven effective, and we have all reasons to expect that the app, stroke riskometer app, in combination with health workers, will be as effective as any other interventions Jairaj mentioned.
Thank you, Valery. Jairaj, you have a comment.
I agree fully with Valery, and no, we have a lot of evidence regarding using mobile technology, and also through the community health workers screening patients for risk factors, and also an inbuilt algorithm, so they can refer to a doctor if they have any problems. So that is probably the best way to move forward.
Yeah, the great advantage, if I can to add to this, of mobile technology, it is very commonly used. That's why we call it mass individual prevention strategy, because in developed countries, 90% of adults use it. In developing countries, 30 to 60% adults use it, and the usage is increasing virtually exponentially. So it's it's a kind of mass prevention strategy, but we also should not forget about population-wide, government-regulated primary prevention strategies as well.
So we are hearing the chiming of the bell, which means our hour is up. I just want to make a very brief comment and say, I don't think anywhere in the last few years we've heard this topic so well covered as in this webinar. So I really want to thank everyone, those staying up, those getting up early, and those enduring us during the daytime. Okay, so thanks everybody and goodbye.